Well, hello and welcome to the last Parkinson's webinar of 2022. My name is Diga Hasters and I'm the head of Parkinson's Academy and chair for this afternoon's sessions. It is my pleasure to welcome the speakers for this afternoon's learning sponsored by Zambon UK. So without any further delay, I'll hand over to Ali to start this afternoon's sessions. Ali.
Great, thank you very much. Let me just try and load up my slides. Can I just check someone can see them? Fantastic. So I'm really grateful for the opportunity to talk to you today about delirium and Parkinson's disease. My name is Ali Mackett. I'm a consultant geriatrician based at Addenbrooke's Hospital in Cambridge. Here are my declarations of interest. So first of all, why are we talking about delirium? So I think the first thing I wanted to flag is how common delirium is in hospitalized patients with PD. And we know when it does occur, it's associated with adverse outcomes. So we know that we see an increased length of stay, potentially worsening motor symptoms, particularly falls. We see a change in the trajectory of cognitive decline after an episode of delirium in PD, and we see a trend towards higher mortality. And this, this is borne out in the evidence. But as well as that, and I hope some of you are nodding along here, in that we have some things that we see anecdotally, and here are some of the personal observations I have from working with lots of patients with delirium, is people with PD have a delirium which is much more severe and long-lasting in clinical course compared to those without PD. And sometimes, particularly if they become hypoactive, the delirium is so severe, it's sometimes mislabeled as someone who's at the end of their life. And I've added in a third one, I put it in red. This is a new one from sort of 2020 onwards. Again, for patients of mine who develop COVID-19 and then have this complicated by delirium, they have a really severe clinical course. And I've had a couple of patients who've needed sectioning after developing delirium in the context of a COVID-19 infection. So be interested to hear other people's thoughts about their observations with this. Again, this is just another slide showing how common it is. So we've shown, I guess, the sort of clinical significance and relevance of delirium in PD, but it's going to happen to almost all patients with PD. So looking at this case series, we can see in the blue line, we've got idiopathic Parkinson's disease and atypical Parkinsonism. And in both categories, almost all patients develop delirium at some point during their disease journey. I'm going to put a slightly controversial slide in here. So we know it's really common. We know what a significant impact it has on patients. But because I'm a geriatrician, I want to be a little bit controversial here. So we're looking at a picture here. And now I see a horse, but a neurologist may see a zebra. And I think that's what's happening in the literature. So there was a group looking at the way that we look at delirium and encephalopathy in the literature. So if you're a neurologist reading a neurology or a neuroscience journal, you'll read articles about encephalopathy. Whereas someone like myself reading a geriatric or a psychiatry journal, I will read about delirium. There's a really significant difference in that. And that's, I think, in some ways held back some of the evidence base, which is very much severely lacking in delirium in PD. And this group got together, it was 10 societies, looking at making sure we've got a really clear understanding about the nomenclature in these circumstances. So when we talk about delirium, this is a syndrome, and it's defined by the clinical characteristics, and we may see those listed in the DSM-5 or ICD-11. When we talk about acute encephalopathy, this is really the underlying process that may cause a delirium. So it's referring to the underlying pathobiological process. And one of the manifestations may be delirium. And I think it's really important when literature is looked at moving forwards that we're using those definitions correctly. So being a geriatrician, I'm going to completely stick with talking about delirium. So it's worth as a reminder for those of you, I'm sure you're all aware about the criteria for delirium. So I've highlighted the really key points in it. So it's a disturbance of attention and awareness, and it really does develop quite quickly. So we're talking about a few hours to a couple of days. And what is absolutely key, and I've had long-standing battles with my discharge planning team, that it represents a change in baseline. So dementia is a huge risk factor for developing delirium. So it's not, we need to look at their baseline and that change as part of it. And it tends to fluctuate in severity during the course of the day. We need to have additional disturbance of cognition. I've listed them there. And it's not explained by another pre-existing condition, particularly neurocognitive disorder. And the eagle-eyed amongst you will see there is a lot of overlap here between, for example, dementia with Lewy bodies and delirium. And I think that's worth a discussion later on. So in terms of a sort of pathophysiology, moving on from that. So we've got our clinical syndrome, but what is underlying it? So I think there's lots of different factors implicated in the etiology of delirium. And given the number of factors that may be driving it, there must be, I suspect, some distinct neurobiological mechanisms. So I've got countless frail older people on my ward with delirium right now. Can we realistically say the mechanism is exactly the same as a 20-year-old in ICU following trauma, having had surgery? So I'll leave that question with yourselves as well. I don't think we've got an answer yet, but surely it cannot be the same mechanism. It's worth thinking about some of the similarities between the clinical presentations we see in particularly DLB and delirium. So could this just represent a neurotransmitter imbalance? Do we see changes and we're seeing a cholinergic deficit? Is there a dopamine excess? Is there a change in melatonin levels? And this slide is taken from a review from Nature Review in 2020 about delirium. And this is not specific to Parkinson's disease, but I think it's quite an interesting look at some of perhaps the underlying pathophysiology. So if we start at the bottom of the diagram and we look at, first of all, systemic triggers. And obviously we're aware of lots of different systemic triggers. So it may be there's acute systemic inflammation and infection, sepsis driving it, hypoxia. It may be there's changes to blood flow. That may be in the context of shock. We may see a metabolic derangement. It could be hyponatremia, hypernatremia, hypoglycemia. And this is going to have an effect on the brain. So if we move up in a clockwise direction, so we could look at neurotransmitter disturbance. So, for example, GABA drugs, anticholinergics, antihistamine drugs have an impact on cholinergic systems, and we've got things like the reticular ascending arousal system involved. So we know that arousal changes during delirium, and we know that is to do with cholinergic tone. So again, these drugs, which are often intimated in delirium, may be having a direct effect here. If we move up and we think about the microglia, these can be primed by degenerative pathology. So as we age, our brain changes, and we see that these are primed to act in a different way. So they get a systemic trigger, and we start having secretions of pro-inflammatory cytokines, things like TNF. And this can lead to neuronal dysfunction and injury. And this can also have an effect on astrocytes as well. These also, if we carry on round, are primed by degenerative pathology. And all of this degenerative pathology is almost certainly going to be accelerated in Parkinson's disease, so they're going to be even more vulnerable. And they may secrete chemokines. It's going to change the metabolic makeup within the brain. We may see changes to the vasculature. So in acute settings, we're going to see perhaps microvascular dysfunction. We're going to see blood-brain barrier injury. And also, again, with aging, we might see already pre-existing changes to the vasculature in the brain, into the blood-brain barrier. And again, that's going to give us changes to metabolic insufficiency within the brain. And if we combine all of those complex changes together, ultimately, we're seeing reduced integration of brain networks. So we're going to see changes at the synapse, we're going to see impairment of neurovascular coupling. And I think this is probably what's going to be leading to that ultimate clinical syndrome of delirium. And I think that's quite complex, but what I use in a kind of clinical setting much more is thinking about your predisposing and precipitating factors. So if we go back to the 86-year-old and the 20-year-old that I was talking about earlier in the talk. So my 86-year-old up on the ward has got a lot of predisposing factors. So he's older, he may well have underlying cognitive impairment, he may be frail, he may have a number of comorbidities. So this means he's got lots of predisposing factors. So the precipitating factor required to trigger delirium is much, much less. Whereas if we think of our 20-year-old with none of those predisposing factors, the precipitating factor has to be much, much bigger to trigger a delirium. So it may be that they're acutely unwell, septic, they've had major trauma, ending up in ICU, gone to surgery, on loads and loads of anesthetic agents, and we're seeing that delirium picture. So it's about your predisposition having an impact on what precipitant is required to trigger a delirium. So in terms of recognizing delirium, I'm sure you're all aware of the different tools out there. I've put up the two commonest tools that we use in clinical practice in the NHS. We've got the 4AT and the CAM. In terms of performance, they're pretty similar. The 4AT is, I think, probably used a little bit more widely because it's quicker to do. It doesn't need any specialist training. And for those of you just to go through that, they are looking at the core features we talked about earlier. So in terms of what it looks at, we first of all look at alertness, and that is a simple score looking at whether someone's normal, fully alert, there's some mild sleepiness, or is it clearly abnormal. Doing a brief AMT4, which is asking about their age, date of birth, place, and current year. And again, depending on the number of mistakes made, it gives you a score. Looking at attention, so it's asking them to tell the patients tell you the months of the year backwards, starting in December. And again, if they can achieve 7 or more, a score of 0, and obviously that score goes up if they're unable to. And then the other key thing is, has there been acute change or fluctuating course? And then you get a score at the end, and it gives you an indication about whether there is possible delirium present or not. The CAM looks at very similar things in terms of looking at the acute onset fluctuating course, attention disorganized thinking. So I'm going to now move on to a clinical case to make it much more, I suppose, clinically relevant. So whilst I'm starting to go through this, if people can start Googling or opening the Slido app, because I want to ask people what they do in clinical practice. So this is a real clinical case. This is from 2018. So it was a patient of mine from clinic. So he's a 72-year-old retired lecturer. We do have a lot of these in Cambridge. He'd had Parkinson's disease for approximately 20 years. He was actually pretty independent, and he was still living at home. He had a once-day package of care just to help with washing and dressing in the morning, but otherwise he was pretty independent. He felt that when I saw him in clinic, he was pretty well controlled. We'd increased his dose about 6 months previously. He hadn't really developed any motor fluctuations, and at that point in time, he was cognitively intact. This was his medication regime. So he's taking Madapar 187.5 5 times a day. He had a little bit of pramipexole once a day, and he took clonazepam at night for his REM sleep behavior disorder. So approximately 4 months later, after I'd seen him in clinic, he was admitted to hospital and he was found to have cellulitis affecting his large scrotal hernia. At this point, he was hugely delirious. So he met all the criteria for delirium. He had this fluctuating alertness, marked inattention. He had very distressing visual hallucinations. And he was very aggressive at times towards the nursing staff, generally verbal. And I was asked to come and see him. At this point, I'm going to give everyone a minute or so just to sort of find the slider out, because I'm going to ask you what we should do. So a few things went through my head when I went to see this man about what we should do and what should advise. So if you can either Google it if you don't have it, and it should be the top one where you can just put the code on the screen in, or if you've got the Slido app. And I've just opened the voting, so I'll give it a couple more seconds and I'll go on to the questions. Everyone's got time for the code. Okay. So this was going through my head. What should I advise? This man is hugely delirious. Should I say to the treating team, look, treat the underlying cause only. Let's not change his usual medications. He was managing okay. Should we stop the pramipexole? He's only on a small dose. He's got hallucinations. Is that causing a problem? Should we reduce the Madapar? Is that contributing to his delirium? Should we add something else in? Should we add in some lorazepam? You know, he's certainly being aggressive and agitated. Should we add in some quetiapine? Again, being a bit agitated, being a bit aggressive at times. Should we give him Riverstigmine? Okay. And I will give people a little bit longer to keep voting. So for those of you who missed it, I'll give you the code again, which is 6407996. So lots of votes still coming in. Okay, I'll give it another sort of 15 seconds or so, and then we'll call it there and I'll give you the results. Okay, right. So what around 60% of you said was saying, let's treat the underlying cause only, and no change to usual medications. About a third of people said, let's go ahead and stop the pramipexole. There were a few people saying we should reduce the Madapar. No one wanted to add in lorazepam. About 10% of people wanted to use quetiapine, and a couple of people wanted to use Riverstigmine. Okay, so I decided to say, let's treat the underlying cause. So I left the team to it. They said the cellulitis resolved, about a week's worth of antibiotics, everything got better. And despite this, despite all the bloods normalizing, he remained really delirious. So he was pretty much the same as he came in. So he had all the inattention problems. He was drowsy at times, agitated at others. He was still hallucinating. He really hadn't improved much at all. And the team asked me to come back and said, look, what are you going to do now? We're 3 weeks in. So I'm going to reopen the poll. Second poll, so it's the same questions. So for those of you who've gone off Slido, if you log back in, it's 6407996. So we're now 3 weeks in. He's still pretty delirious. What would you do? Do we hold our nerve and say, don't change anything, stop the pramipexole? Do we reduce the Madapar? Do we add lorazepam? Do we add quetiapine in? Do we add in Riverstigmine? again, I'm going to give you a couple of minutes to have a reflection on that. Give people the chance to vote. So people are still making their mind up. It's fluctuating still. And again, if you're still trying to get on the app or trying to vote, it's 6407996. Okay, a few more seconds. Right. So I'll tell you what the scores on the doors are now. So in terms of treating the underlying cause and saying no change to anything, this is now the minority option. It's only 6%. 61% are now saying stop pramipexole. 1% are saying reduce Madapar. 3% are saying add in lorazepam. 15% are saying add quetiapine, and 15% said add rivastigmine. So that's really interesting. That's going to be really helpful for the latter part of my talk in terms of having a bit of a discussion. So I'm obviously a massive outlier, I was in the 6%, and I said, let's hold on, let's not change the medications. So we didn't change them. We said, actually, he's well controlled at baseline. He felt his motor symptoms were well controlled. He was cognitively intact. And actually, after just over 4 weeks, he had improved. And for interest, we did an ACE, Adam Brooks Cognitive Examination on discharge, and it was in the normal range. And he did return back to his previous level of function. He's back again with his once-a-day package of care back at home, and then he was due to have an elective hernia repair. Now, what's interesting, I've got an update for this man. So this happened in 2018. He was in my clinic in 2022, and sadly, he's developed Parkinson's disease dementia. So that is an interesting thing. Was this first bout of delirium, one of the warning signs of what was due to come? So let's talk about, in the second half of the talk, about the pharmacological management of delirium in Parkinson's disease, because we've talked about loads of options that we could do, but let's see what the evidence is. So we certainly talked about reviewing medications, and I think that in terms of clinical consensus is probably where most of us would go. There's no real evidence for it, but it makes sense, doesn't it, that we should be reviewing, reducing, withdrawing medications with the least motor benefit and the highest delirium risk. And we certainly can debate what order you would do things in, but you could get rid of anticholinergics, samantidine MOBs, etc. And we try and leave people on simple regimes, usually with levodopa. So that makes sense. But again, we haven't got huge amounts of evidence how to do it, how effective it is, what time scale to do it over, at what point in the delirium do you start thinking about withdrawing drugs. Secondly, we talked about lorazepam, and I'm sure many of you have delirium guidelines in your respective trusts. And it says, do not use haloperidol, use lorazepam in people with dementia, Lewy bodies, or PD. So despite it being first line, there's actually no high quality studies regarding the use of benzodiazepines in delirium of any cause, whether it's PD or related or not. So there's a single study, and this is in a non-PD population of just a few patients, saying if we give them haloperidol plus lorazepam versus haloperidol versus plus placebo, there is a slight reduction in agitation at 8 hours. So I think there's a big question mark there, isn't there, about lorazepam use? We use it widely, but there isn't a huge amount of evidence base to say what effect it does have. So what about rivastigmine? A minority of people have said, maybe I would use rivastigmine in this patient. So should we be using it in delirium? So there's some small papers saying, well, actually, maybe it does help a bit. So there was a paper looking at patients who've got cognitive impairment. This is not in PD, but we're having to extrapolate the evidence. But they've got cognitive impairment pre-existing that, and they're going forward for surgery. And people who are given rivastigmine patches 2 to 7 days pre-op, it seemed to significantly reduce the incidence of and severity of post-op delirium. So that's a potential tick for there. There's another paper saying if you've got pre-existing dementia and you come into hospital, if you are taking rivastigmine before you come in, you are less likely to get delirium in hospital compared to someone with dementia who isn't on rivastigmine. So that's another thing that makes you think, oh, maybe this is a potential answer. There was another paper looking at adding rivastigmine to antipsychotics in someone who's got chronic long-lasting delirium. And obviously some people did improve, but they found there were some people who were non-responders, and those non-responders had a poor outcome. But for us, and the relevance to us is it's those that have underlying neurological conditions tended to be the poor responders. But then if we look at rivastigmine in a bit more detail, and we look at perhaps slightly bigger studies, does it do much? There was a Cochrane review which looked at using rivastigmine, and this is the top one here. This is just sort of the headline from it. Using rivastigmine in the non-ICU population. So there are patients that we're going to be seeing on the wards, and saying, does rivastigmine make a difference? And it looked at a whole host of things. So its primary outcome was, does it reduce the duration of delirium? And the short answer is no. Does it have any significant impact on any of the other things that we're interested in? Things like mortality, things like agitation, things like use of other drugs or rescue medications. There were no significant differences found. But you can see the number there is tiny, 15 patients. Is it going to be powered enough to see a difference? It didn't seem to show any trend for increased adverse effects. But if we come down to the right-hand side of the screen, some of you will be well aware of this paper, which was conducted in an ICU population, where they looked at using rivastigmine in addition to usual care versus placebo in treating delirium in ICU. And this study was stopped early because there was a significant difference in mortality for those in the rivastigmine group. So rivastigmine seemed to worsen the outcome for those in ICU. And it goes back to the question that I had at the start, which is, really, are we looking at the same population, that ward-based frail patient versus the ICU population? That's interesting. Obviously, we're having to extrapolate lots and infer lots of bits of evidence because there's just not much out there. But if we look at papers looking at using rivastigmine in non-dementia in PD, so this is a paper looking at people who've developed visual hallucinations and looking at whether they get benefit in terms of reducing their risk of developing psychosis, developing dementia. Effectively, there is no significant benefit there. So in summary around rivastigmine, I think the jury is still out, and I'm really interested to hear people's experiences of using rivastigmine, whether they use it at all or not in delirium, and what they found. So then what about antipsychotics? That was another thing that I put up to say, should we be using antipsychotics in the management of delirium? So clozapine is obviously the most well-studied drug in PD psychosis, and it seems to be probably the most effective. But as you're all aware, there's a huge regulatory framework associated with it. And that means it's going to be difficult to use in the acute setting. Plus, obviously, patients with delirium may well have issues with things like infection. So given the risk of agranulocytosis, etc., do we want to be using it in the acute phase? So then we're left with, well, other antipsychotics. As you're all well aware, a lot of them will worsen motor symptoms, and obviously they're already struggling with their motor symptoms in the midst of their delirium, so tend not to be used. Then what are we left with? Quetiapine, which we're all familiar with and we do use quite regularly, but again, I'm having to infer evidence from psychosis in PD because there's not a huge amount of evidence in delirium. and quetiapine use. And what we can see is quetiapine, the evidence is very much mixed. So there are short case reports and little case studies saying maybe this is helpful, but then when you look at it in a randomized control trial setting, you see that it's often no better than placebo in terms of risk in managing psychosis. So just to sort of finish off the talk, it is really common. Hopefully I've shown you in this brief talk about how common it is. So 75% of your patients are likely to develop delirium at some point during their clinical course. And despite this frequency, and despite the fact that we know it's associated with adverse outcomes, with poor outcomes, there's actually a real lack of evidence around delirium in general, but particularly in PD. So as you saw, we don't really understand the pathophysiology of delirium. We don't really understand the driver for it. So we can trigger a delirium in animal models by making someone hypoxic or hypoglycemia, but that's not what we see in clinical practice. We see patients coming in with a trivial UTI, for example, triggering it. So that can't be the full explanation. We don't really understand the trajectory of delirium in people with PD. I certainly see if they've had a episode delirium, perhaps a more rapid cognitive decline, and there is obviously a strong association with developing or future risk of developing dementia. And as we've just gone over, there is a real paucity of high quality evidence about how we should really be managing these patients in PD. And the problem is with anecdotal data, with short, case series, delirium on the whole should get better. So it's very difficult to infer something without well-designed studies. So I'll finish up there. Here's some reference of the sort of papers we talked about. So if I finish up, and then people can certainly ask questions if they wish.
Ali, thank you very, very much. That was brilliant. A whistle-stop tour, as you said, but real food for thought. As we wait for some Q&As to come in, I wonder if Emily Henderson, you would like to come in at all, and let's talk about your experience for a little while in this area. Emily.
Yes, I thought it was absolutely brilliant talk, Alistair, absolutely fascinating. And a lot of what you said really chimes very true. I think for people who are at the sharp end and invariably see older people who have Parkinson's are admitted, and delirium is, as you say, almost an inevitability. And I think it's really interesting to look at those two factors, isn't it? The predisposition and then the acute precipitants that tip it over. And my passion, as everyone will know, I don't think this will be new news, is looking at the cholinergic kind of vulnerability and how that confers susceptibility to delirium. I'm so struck by the fact that you presented that last slide on the efficacy or potential efficacy of Riverstigmine, and it only recruited 15 patients. And I just wonder whether actually the problem we've got here is that it's underpowered. And I don't know, it's a bit of a call to arms. I just think as geriatricians, we see so much PD, we see so much delirium. Surely, again, as a trialist, we could just do a bit better than this in terms of testing some of these compounds. But I'd be really interested to hear what your views were on that as well.
I think so. I mean, I think in theory, you think it should help, but I completely agree. I imagine it was underpowered. It almost certainly was underpowered to see any effect. And I suppose people were a little bit spooked by the ICU trial a few years ago, where they saw obviously the mortality risk, and it was quite significant, and they stopped the trial early because it was a very early signal. So I suppose people are a little bit nervous about using it. And you're right, we do need high quality trials, because we end up doing something and we infer there's benefit when the trajectory might be they've been improved anyway. So for example, if I gave that case again, and that's generally what we did, and I gave a Riverstigmine patch and he improved, I'd be patting myself on the back saying, great, this was really fantastic what I did there, and that made a difference. Or I'd stop the pramipexole, which many people said they would do. So, well, that's obviously clearly what needed to happen in that situation.
There are so many cognitive biases, aren't there, in clinical medicine that we fail to acknowledge so often. And I think sometimes that's the beauty of trials, particularly high quality randomized trials, is that we try and eliminate a lot of that bias in terms of we still select people. But I think we mustn't be so spooked, because we practice in an area where there is such high risk often with older people and people with PD of mortality, particularly in the setting of delirium, that I think we must strive to do better, actually, both in terms of, as you talked about in your initial slides, the recognition of this as a syndrome, and then really aggressively try and identify and reverse those precipitants. Because, as I say, it really struck a chord when he said it looks a lot like dying. And I'm sure many of us have seen cases where we've sort of come in and thought, oh, hang on a second, this person isn't in their last final hours. Actually, there's something we can do, and there's sort of Lazarus-like people recover, which is always really encouraging. But I think we owe it to kind of juniors and other non-specialists to make sure that people are really sure that this is not dying, it is delirium, and it can be reversible. And the response, when you get it right, to then, it's so gratifying, isn't it, to then see people in clinic in 3 months, 6 months who are living very fulfilled and kind of joy-filled lives.
Absolutely. And I think that the issue we've got is everything's under pressure now, and it takes time. So even if you remove the precipitant, and obviously I didn't have full time, and obviously Jacqueline, who was due to be here, was going to talk a lot about the precipitants and the general management. I was focusing very much on some of the drugs that we sometimes use. And there's a question here I can see about it's really difficult about not to prescribe something if the ward's understaffed, and there's this huge pressure that everything has to be done at 100 miles an hour, that because we're understaffed, because there's not enough beds, people need to be getting through their delirium as fast as possible, and therefore people are using drugs to perhaps ameliorate the risk of harm to others, and we just don't know whether that is creating more of a problem or not. The evidence is just not out there.
Ali, there's 2 more questions if you have a look.
Yeah.
If you scroll down from that one. So there's one about what would you say is the average length of delirium PD patients once their intercurrent illness has been addressed? And is it different from the length of delirium in other patients?
I think it is, just from clinical experience, that it does tend to be long lasting. My record patient is 6 months of delirium before returning back to their baseline.
And Emily doesn't seem surprised by that.
So they were in hospital, went to a delirium interim bed, into a nursing home, stepped down to a residential home, and then they got back home again at 6 months. So I think it is longer lasting, but as I said, this is anecdotal personal data I was giving, because I don't think anyone's done a comparison between delirium in the non-PD population. And it does vary, but yes, I'd say it's longer. And in terms of once you've stopped the acute precipitant, how long does it take to recover? It is variable. I think there are some patients where they turn around quite quickly in a matter of days. And I've got someone on the ward, one of my patients on the ward at the moment, where we've treated the underlying infection. 3-4 days later, he's starting to come out of the delirium and back towards his baseline. But we see other patients where it is long-lasting, fluctuant, and actually they never get back to their baseline, and they go to a care home, and we use delirium interim beds where people aren't able to manage at home. And we know about 75% of those patients remain in the care home long term, and only about 25% return home.
Right. There's a question about your thoughts on your management, I think, if they're aggressive with their delirium. So
Jacqueline would have been excellent to answer this. So it's a real shame she can't be here. So she is one of our specialist dementia nurses. And a lot of it is around environment. So we have a lot of discussion internally here at Addenbrooke's. We've got a number of different wards. And the ward I'm on was nominally the sort of delirium and dementia ward. And actually, although we've got the same footprint as some of the other wards, actually, the calmness in our ward is quite different to some of the other wards with the same footprint, because we've got a different environment and we've got a different approach. We've got space, we've got tables, a cafe area for them to sit at. We've got staff training to look at diffusing the situation, allowing people to move around the ward, to let them sit and do something with meaning, to do games and things is somehow a lot better way of calming patients down than often you see in some wards, where people are saying, sit down, they're trying to get out of the chair without looking at, do they need the toilet? Are they thirsty? So I think the first thing I would do is all the non-pharmacological stuff with the aggressive patient. And we know all the things about making sure we've got lighting, reorientation, involving familiar people to them, trying to keep the ward calm, quiet, giving that space, checking for things like, are they desperate for the loo? Are they in retention? Are they constipated? Are they in pain? Looking for all these factors before I sort of dive in with anything too much. So it's looking at those things first. If you've absolutely certain you've looked at all of the reversible factors, you're treating things, you have addressed those non-pharmacological things, then you would think about drugs. And in PD, you might use the lowest dose lorazepam or a low dose quetiapine if you really had to, but I really try not to, because you end up dealing with falls, over sedation, and all sorts of problems.
Excellent. We've got 1 minute left, Alice. So if you had, in that 1 minute, you're in an elevator and you have to tell somebody what is the most important thing with delirium in Parkinson's, what is it?
I think it is recognise it, because we can't treat it, we can't do research in it unless people are recognising it. So it's looking for those key features we talked about, and it's the change from baseline. So it's talk to the family members who know them best to see that change, because there's a tendency for people who are not specialists to assume everything that is their baseline, whereas actually you need to find out from the family. They're not normally sleepy, they're not normally unable to walk, they're not normally hallucinating. So
Brilliant.
Identifying is the key message, I think, and then we can move from there about treatments and things.
Thank you very much. That was absolutely brilliant.